Thank you very much, and I'm sure you're all as surprised as I am taking this talk, which actually belongs to Dr. Nalini Marjan. It was just a personal issue that she was not able to come here, so I stand as a surrogate for Nalini Marjan, and I hope you'll excuse me because I'm actually a surrogate even for her slides as well. Okay, so we're looking at ovarian stimulation and onco-fertility, and I would be talking on her slides here, which I had the opportunity of getting it just about an hour ago. Okay, so if we have to look at the outline for oncology, why does a person need fertility when you're really sort of, put across with a diagnosis of cancer? It's absolutely the last thing on your mind. However, it is understood today with good medical treatment and good therapies available that more women in their reproductive age is going in for not a 5-year survival but quality of life extension. And if they happen to be in the reproductive age group, and if they've not completed their family or not had a family and they have an opportunity to have one, trying to mainstream these people is an important thing. So what exactly are we actually facing here? We will need to look at the menstrual cycle. We need to look at the time required for getting the eggs. We need to counsel her whether she wants to go in for reproduction, because not informing her is a crime from our side, but making a personal choice after being informed is her choice. So physiology of follicular development is what we would look at. Constraints on oncofertility. What are the ovarian stimulation protocols and protocols in breast cancer or hormone sensitive cancers, and of course our conclusion on this. So throughout our ovarian stimulation, which we will be having tomorrow in great depth, I would like to tell you I'm not talking about actually the stimulation process itself, but the kind of theories behind it. Now when you have a normal cycle, the luteal rise of FSH initiates follicular recruitment of the FSH sensitive follicles. So in most places, is there a pointer? There's no pointer here. Is it coming? Yeah, it's coming, but it's not showing on this. It shows here. Okay, so what we are actually trying to do is to enlarge the FSH window. In a normal cycle, your FSH window is narrow, whereas if you look at a stimulated cycle, your FSH window is widened. And then if you go for a mild stimulated cycle, it is narrower than the conventional stimulation, but larger than this natural cycles. So what we are trying to do in shortest possible time, can we get these oocytes and can we actually give her a quality reproductive life after cancer? So our understanding was, and perhaps when I did medicine and as many of my other colleagues would have done, we thought follicular phase was sacrosanct for development of follicles and luteal phase was to keep that embryo, fertilized embryo, inside the uterus so that it could grow. But there's a lot of change that has occurred over the years as to how we actually view this process. And suppose I were to tell you that there's a continuous process of recruitment even in the luteal phase, then one would say, oh my God, I didn't know that. But mind you, with only follicles in the follicular phase, we still have a lower AMH, when you compare ourselves to our counterparts in the Caucasian population. So continuous recruitment is something that the policy is what we are going to use here. The second one is cyclic recruitment of follicles. A single wave of cohort of 2 to 5 millimeter follicles is recruited once, and that was way back in 1979. And then in 1997, we have Bart Fauser et al., who says follicles at comparable but not identical stages of development are seen throughout the menstrual cycle. Now, what is this multiple waves that we have? 2 to 3 synchronous growth of a group of follicles occur at regular intervals through the menstrual cycle, and follicles in each wave are similar but not identical. So there's a sea of difference from 1997 to what was in 1979. So given that we have that kind of a difference today, we need to understand in follicular recruitment of the luteal phase. in vitro maturation studies says existence of healthy antral follicles in the luteal phase was attributed to the emergence of a new wave of follicular development in the luteal phase. So it is a dynamic process. So healthy antral follicles available for recruitment in all phases of the menstrual cycle, and that is something which we are now utilizing in cases of cancer treatment. Why do we need different stimulation protocols in oncofertility? Because A, there is a constraint of time, and secondly, they would not be on the second day of the period every time, so therefore you would have to look at whether you want to stimulate this earlier or you want to stimulate later, or just take her as she comes and then start stimulating. So breast cancer, at least 4 to 6 weeks are available between surgery and chemotherapy. The hematological malignancies, the urgency to start cancer treatment is important. So therefore, that would be our overriding strategy, that we would not compromise on the chemotherapy or the radiotherapy. But if in that small window, can we get her follicles, is what this talk is all about. So the other thing is, of course, if you wait too long, is the risk of metastasis. Now, what are the concerns and constraints in oncofertility? One, that where the steroid levels are high, that is a concern for hormone sensitive cancers. The second is the risk of complications like the OHSS, which means again your estrogen levels are sky high. And of course, do you obtain adequate number of M2 oocytes at any stage of the menstrual cycle is of course a thing that we all need to understand. And ultimately, and it's certainly not the last, but it is an important thing that I want to put, is what is the state of health for that lady and what is her age from a maternal perspective as rights issue, and also the unborn child as a fetal rights issue as well. So as gynecologists and oncosurgeons, we play a very important role, and one has to look at this to say, are we going to give pregnancies to everybody, or are we going to give pregnancies to those who can go through the pregnancy? So it is a question that we will have to ask ourselves, that the person sitting before you, if she were to be your sister or your daughter, would you advise the same thing? And if the answer is yes, then you'll have to give her an informed choice. You must give a cooling off period for her to take a decision, because she's just been given this devastating information of having cancer. You'll have to allow her to absorb it, but time is an important factor. So therefore, can we give that kind of time? So when this actually is in the stage of diagnosis, I think information, pamphlets, etc. can be given to this person to actually look at it, and also get the partner involved, because this is extremely important. They need to have that support. And what are the anesthetic risks and surgical risks? So what would be the prerequisites in these situations? Medical condition does not preclude safely carrying out controlled ovarian stimulation or oocyte retrieval. Reasonable chance of responding to controlled ovarian stimulation. The AMH and AFC have also to be looked at, and adequate time is available to go through the stimulation and carry out the oocyte retrieval. Now, what are the stimulation protocols for the IVF? You have two standard regimes, which I don't go into detail. It's the GnRH agonist protocols, and which is the down regulation of the pituitary plus stimulation. That's the short, long, and the ultra long. And then you have the antagonist protocols, which will be with gonadotrophins or oral agents and gonadotrophins. So ovarian stimulation starts from day 2 of the menstrual cycle, and GnRH analog added to prevent premature LH surge before or after start of ovarian stimulation. So look at the antagonist protocols, the fixed and the flexible ones. You have the recombinant FSH about 200 to 250, 225 units starting from day 2 of the cycle, and then by day 5 or day 6 you then individualize this, and you either give 0.25 antagonists daily or a single dose of 3 milligrams of antagonist, and then the stimulation is individualized, and the dose of FSH and the HMG is individualized. So roughly about 12 to 14 days is required to complete the ovarian stimulation. From the cycle day 2, around 8 to 10 days is what we would expect. So what happens in stimulation with onco patients now? You look at the conventional protocol, and you look at the crash protocol and a random start protocol. So to achieve the crash protocol, what you need to do is a quick down regulation. So GnRH antagonist given as a 3 milligram bolus in the luteal phase, or a daily dose of 0.25 milligrams subcutaneously for 2 to 4 days to achieve the down regulation. And then you start the stimulation at the onset of menses. The total time for cycle completion would be around 16 days, 12 days and plus 4 days for the down regulation. Dose of FSH based on oocyte retrieval would depend upon the AMH, AFC, FSH and BMI. So the random start protocol is effective method for emergency fertility preservation, random start controlled ovarian stimulation. So you start ovarian stimulation on the day the patient presents, any day of the cycle. So if you looked at this, those people with breast cancer, if you looked at the conventional start, which were number 93, and then in the random start, it's 35, you found that 66 were in that group and 27 was in the random start group. And you didn't find much difference. The late follicular phase, that is M+7, menstrual cycle day 7, emergence of a dominant follicle of more than 13 millimeters, and a peak is a progesterone value of less than 2 nanograms per ml. The luteal phase, that is the progesterone level of more than 3 nanograms per ml. So you have these two categories which you have to look at. Ovarian stimulation started on day 2 to 3 of the initial consultation. Okay, so E2, progesterone, LH were measured during every visit. So stimulation started with gonadotrophins. Starting the antagonist is dependent on the size of the secondary follicle. So we are now trying to get the secondary follicles into recruitment following the lead follicle. And as soon as the secondary follicles reach roughly around 12 millimeters, antagonist is started. And this could be before or after the spontaneous LH surge. There are two scenarios here in the luteal phase start. One, ovulation was induced with HCG or GnRH agonist when the dominant follicle reaches about 18 millimeters in diameter, and then ovarian stimulation started 2 to 3 days after HCG or GnRH agonist trigger. The reason here is that if you have a follicle already developing, and if you don't allow for ovulation to occur, you may have a cyst formation, and therefore you would not get enough of follicles in the luteal phase. So the patient has come post ovulation, which means ovulation has already occurred. Then antagonist is added when the follicle size reaches 12 millimeters. Now this is a bit of a busy slide, and therefore I'd just like to explain to you here that what you see on the top in the circle over there is the progesterone value, and in the luteal phase post ovulation the progesterone value is high. So as you start stimulating, HCG trigger given there, then start of ovulation, ovarian stimulation, then start of GnRH agonist post ovulation, which means the progesterone is high. You have an LH which is quite low down there. This pointer doesn't show well. I wish we could get a different pointer later on. Okay, and then you see the estrogen level rising. The green kind of hillocks that you see there are all the follicles. So if you look at this, the HCG is stimulated. Though you give HCG twice in this particular cycle, this is in the luteal phase. The first HCG is to just crack the dominant follicle so that you can get more stimulations of the secondary follicles, and the second one is to collect the oocytes. So if you look at the next slide, if you see the total days, the days of ovarian stimulation and total dose of gonadotrophin between the conventional and the random start, though there is a slightly higher level of estrogen, you will find that it has been significant to an effect. So how do we manage the higher estrogen value, but we still want to have the number of follicles? So let's look at this one. So some interesting observations that have come out is spontaneous LH surge in late follicular start for cycles did not alter subsequent development of follicles of less than 12 millimeters and growth similar to the conventional stimulation. Follicles develop in the luteal phase cycles was similar to the conventional cycles, and even in the presence of a corpus luteum and high progesterone values, which is another important factor that I want to put across, because we are not going to transfer those embryos. So therefore, even if there is a progesterone which is high, it still doesn't matter. You will awaken all the secondary follicles. So in the luteal phase, corpus luteum regression, decrease of progesterone values observed, and ovarian stimulation. Some patients had even progesterone withdrawal bleeding in the during the stimulation, which still doesn't matter. So LH surge effects on ovarian stimulation, GnRH agonist was able to mount an endogenous LH surge within 7 days after the spontaneous LH surge. which means that if you have a 21-day cycle, just give me 5 minutes please, if you have a 21-day cycle, you can expect follicles in a conventional cycle to even come up as early as 7 days. So you are able to induce a second LH surge in this patient with just a 7 days difference. So 2 endogenous LH surge within a week did not affect the oocyte yield or the maturation. So what are the special situations? So here we have Angelina Jolie, of course she is divorced now, but a double mastectomy, and she got her breasts out. Now, controlled ovarian stimulation in breast cancer, how do you manage the high estrogen levels achieved in ovarian stimulation? Because they are of concern in patients with estrogen receptor positivity. So, addition of letrozole of 2.5 milligrams up to 10 milligrams per day helps to reduce the estrogen but does not reduce the follicular output. So, therefore, giving letrozole in addition to gonadotrophins keeps the estrogen levels down and still gives you the amount of follicles that you want. Now, tamoxifen is again anti-estrogenic, but it is not on the it's anti-estrogenic on the breast. So, therefore, even if there are high levels of estrogen, the tamoxifen protects the breast. So, a dose of 20 milligrams per day is started during the treatment cycle for the period of treatment where the estrogen values are high. Prospective data regarding recurrence within 2 years is reassuring, and comparison stimulation versus unstimulated women with breast cancer is also reassuring that there has not been much difference. So, advantages of letrozole here is that it controls the estrogen level and keeps it below 500 picograms per ml. It decreases the required dose of gonadotrophins, no detrimental effect on the oocyte yield. So, if you look at tamoxifen, while it does not have any effect on the estrogen value, tamoxifen citrate antagonists breast and agonist in the endometrium and is used since over 30 years in young breast cancer patients to reduce the recurrence and improve patient survival. Used in spite of occasional reports indicating significantly elevated estrogen levels during tamoxifen treatment, has not increased the resurgence of cancer or recurrence in these patients. So, if you look at the aim here is to evaluate the safety and efficacy of tamoxifen co-administration during conventional COAH in breast cancer patients. Designed 2 groups, retrospective descriptive cohort study. The results as far as the E2 levels were concerned, if you see in the postmenopausal women on tamoxifen with chronically high, that is a mean of 2600, sorry, that's all, this one, on tamoxifen were chronically high, and women going through controlled ovarian stimulation was about 6,924, where you have given letrozole, gonadotrophin and tamoxifen. So, if you look at the oocyte retrieval number reduced in association between where you have a BRCA1 mutation or a poor ovarian reserve, you find that is the number of oocyte retrieval affected by cancer? The answer is no. And you will see that both the studies speak from both sides, so many more RCTs are required in this. What about the cancer of the endometrium? It's a hormone receptive cancer, MRI to rule out invasion, so it has to be early cancer in the endometrium. Long term, up to 6 months treatment with megestrol, medroxyprogesterone, and controlled stimulation with letrozole to reduce the estrogen levels. But here tamoxifen is not used because the levels are going to be high and the cancer is in the uterus. So in ovary it's the same story, and ovarian tissue cannot be preserved. So therefore, after conservative surgery in unilateral tumors, then go in for the stimulation and go ahead. So in cervix, of course, conization, radical tracheotomy and transposition out of the radiant zone, and non-hormone responsive conventional stimulation and a transabdominal pickup. So dilemmas and complications: maximizing oocyte yield, OHSS and cycle cancellation. So we could do in approximately 63 days, that is the interval between surgery and chemotherapy, you could get 2 oocyte yields in these patients. You could get many more oocytes for them, and you can follow these people up that there has not been any difference between a single oocyte retrieval to a double oocyte retrieval, not even too much of difference in the time taken, and therefore people can go in for a double oocyte retrieval in these cases. So OHSS and cycle cancellation, you'll have to balance between heavy stimulation to get maximum yield for cryopreservation against the risk of OHSS. So you also have to look at the last thing of cycle cancellation, particularly where you have poor ovarian reserve and older age group. Of course, these have to be explained to the patient before you take anyone onto the treatment. So my conclusion here would be that fertility preservation is a feasible option in cancer patients, preferably done before starting of chemotherapy, and oocyte retrieval or mutagenesis should be reduced because of that. Then proper pre-operative assessment and integrated counseling throughout the procedure is very, very important, as long as she knows what is her rights as well as her responsibilities. Minimize the risks of the procedure. Random start or crash protocols allow a quick start of ovarian stimulation without compromising oocyte retrieval. Tamoxifen should be used in estrogen positive cancers, and letrozole to keep the estrogen levels low. Follow-up for recurrence so far has been reassuring, and of course current recommendation would be oocyte or embryo preservation not to be done between chemotherapy and wait 6 months post chemotherapy before conception has been the last word here. So with all this, I'm sure all of you, do you know who this lady is? She has been diagnosed with ovarian cancer at the age of 25 and now a mother of 2 children. Any guesses from the audience? All sleeping, hypos? No? She's one of the US TV actresses. Her name is Kobe Smulders, and she's had 2 babies. Not that everyone will have 2 babies, but what I'm trying to say is that we can hope that even in these kind of dismal situations, that there's always a light at the end of the tunnel. Thank you very much.